All right, happy April Fool's Day. Gave you a few ideas. I thought this one's just mean. If you like Oreos, this is just mean. Any good April Fool's jokes? When our kids were younger, they loved playing tricks on my wife and I. They thought they were so funny. You know, sometimes as parents, you just kind of play along, right? You're like, ooh, my slippers, I wonder what's in them. Okay, so we're starting a new unit now that it's April, and it feels a whole lot like spring outside, right? How many of you were in town for Easter Sunday with a snowstorm? Wasn't that amazing? That's Flagstaff for you. Okay. A couple of housekeeping things. So this week we have 2 quizzes due on Friday, 9 and 11. Friday by 11:59 p.m. So maybe take one tomorrow, Wednesday, and then save the other one for Thursday, Friday. Spread it out a little bit. Sound good? 2 quizzes due Friday. Remember, we're going to drop your lowest exam score, and we're going to drop your 2 lowest quizzes, textbook quizzes. Just as a reminder. Okay, and the bonus opportunities, we kind of have it scheduled where there's bonus opportunities for every unit that we're in, every exam. And the final is more of an exam 5 than a true cumulative final. So it's mostly over Unit 5 stuff. There's going to be cumulative questions, but it's going to be 80% or more Unit 5 material. Okay? The other thing is, so how many of you love Canvas? Yeah, I don't see any hands shooting up right away. Canvas is pretty clunky. It's very clunky if you do special things in the classroom, like have bonus opportunities that are worth 0 points, but have the opportunity for 14 points. Canvas doesn't really know what to do with that. Canvas struggles when you drop lowest quizzes or lowest exams. Now, we figured out there is a code for that. So I spent a decent amount of time on with IT last week. And after we finish out, we've got some institutional excuses. People had pretty bad health stuff going on and funerals, and it was a rough week. So we've got some makeup exams. Once we get all that finished, we will probably have Canvas in a moment in the semester where it's accurate on your grade. Now, your midterm grades are accurate because I actually put those in manually. But then Canvas, after exam 3, should be accurate by the end of this week, and I'll let you guys know, okay? It's tough because it doesn't like the bonus opportunities. You put the bonus opportunities in there, and it counts it out of 14 points, and so it shifts your grade. So right now, you'll see the bonus opportunity 1 and 2 are gone. And the only thing that's showing in Canvas for exams 1 and 2 is your exam total, which was your exam 1 plus the bonus. Exam 2 plus the bonus 2. Does that make sense? So exam 3 shows all of the information right now because we haven't finished it up. Once we finish it up, we will make those other columns go away, and then it should be accurate. Right? Because some of you are going to have to make that call. Do I take the final or do I not? So I have to have Canvas be accurate before that happens. You with me? All right. Any other okay, question. When is exam 4? Exam 4 is the week of 4/15. It's on a Wednesday, so it'd be the 4/17. 2 days after taxes are due. What? I mean, come on. You guys are like, what? Any other questions? Okay. What did the baby corn ask the mama corn? Where's popcorn? Nicely done. What has 2 holes? That wasn't very genuine, that response, but I'll take it. What has 2 holes, no legs, and runs? 2 holes, no legs, and runs. Want to keep it clean. Like someone's like, I wasn't even going there, Keller. A nose. Nicely done. Why does DNA have no fashion sense? Why does DNA have no fashion sense? Because it always wears the same old jeans. You didn't like that one either? Tough crowd. Wow. All right. I thought those were like hand selected today. They weren't even random. I picked the funniest ones. Shot down. Okay. So peripheral nervous system. We just left nerve physiology, central nervous system and nerve physiology. And I told you the reason I like to do it this way is I like to talk about the nerves before we talk about muscles. And I know in lab you talk about muscles for weeks because you're identifying muscles and talking about what they do. And we haven't gotten to muscle physiology yet. And we're probably going to make some adjustments in the future with lab and lecture to try to kind of get them to line up. But this is a week where they actually kind of do line up, pretty close. What I mean by that is in lab you're going to be covering brain and cranial nerves, right? This week, brain and cranial nerves. So you should be pretty prepped for brain and cranial nerves because that was what we just, went through. Now, cranial nerves are really part of the peripheral nervous system. So we're going to cover the cranial nerves today and Wednesday. Right? And in lab, we kind of package them with the brain because they come out of the brain, but they're technically part of the peripheral nervous system. And I think I mentioned that earlier in the semester. So, peripheral nervous system, chapters 9 and 11, those are your chapter quizzes that are due. In this picture, we've got an image of autonomic neurons in the enteric nervous system of the digestive tract. And what's fascinating about the digestive tract is it is almost as if it's a third nervous system, meaning you have central nervous system, you have the peripheral nervous system, and you have this enteric nervous system, which is technically part of the PNS, or the peripheral nervous system, but it really behaves independently. And it behaves independently because it's so important for your digestive system to operate smoothly. That's where you get your source of what? What does the digestive system do for us? Come on, I got to wake you all up. Serotonin. Think of something even simpler than that. Basic function of life. Nutrition, right? If you eat something, you consume something, and it passes too quickly through your system, it comes out the other end in the form of what? What's the clinical term? Huh? Feces? But if feces moves through you, if the food moves through you too quickly, it comes out as diarrhea, right? And you have very little ability to absorb nutrition. In contrast, if it moves too slowly, now the patient has constipation and very uncomfortable. And some of you kind of giggling and things like that. I know these are funny words, but newsflash, if you're going to be in medicine and you're going to be treating patients, you will be dealing with this, especially if they're older patients. A vast majority of the issues that our older patient population wrestles with is digestive. Digestive. That is the number one thing that you'll be dealing with if you're taking care of older patients. So the digestive system, part of the peripheral nervous system, but almost operates independently on its own. So which part are we studying right now? Well, we came out of the central nervous system with the brain and spinal cord. That was the last unit. Before that, we mentioned this flow chart. We mentioned this flow chart. We're coming back to it because we're going to fill out more of the peripheral nervous system. We looked at dividing it up in sensory and motor. We looked at visceral and somatic. And we made this other terminology known as the autonomic nervous system, which is synonymous with the visceral motor system. So you'll see us use those two terms interchangeably in textbooks and in lecture. So the autonomic nervous system has two main divisions, sympathetic and parasympathetic. We touched on that earlier in the semester. We're going to come back to it, and we're going to get into the weeds. That's what we're going to be doing over the next 2 days. You with me? So this is where we're headed. So what does this autonomic nervous system do for us? Also known as the visceral system. It unconsciously controls or operates or oversees or has jurisdiction over functions that you don't have to think about. Like basic body functions. There's a whole list here. Body temperature, digestion. We just talked about why digestion is so important. Heart rate, metabolism, breathing, defecation, urination. We'll look at reflexes again today. We're going to bring that topic back from the last unit. And we'll talk about a urination reflex, or what we call a mituration reflex, and pupil diameter. So in this room, if I was to shut the light off, right? If I was to shut these lights off, your pupils will start to dilate, right? We get dark in the room, your pupils will dilate, and then I bring the light up, and your pupils are going to constrict, right? So do you think about that? No, you don't even have to think about it. It happens automatically. It happens due to the visceral or autonomic nervous system. Okay. We left Unit 3, and I refrained from asking some test questions in a significant way, right? So let's bring back some of that material. It's a review material. It's pretty fresh. It's just last week. We actually had this exact question. You remember? It was a week ago we had this exact question. It wasn't on the exam, was it? No. Could it be on the next exam? Yeah. So, yes, it's cumulative, but we're going over it again in lecture because it's really important information. And it actually helps to bridge Unit 3 information with Unit 4 information. So I think it's pretty valuable because it should help you understand or comprehend what's happening. So we've got a spinal cord prep. We've got a question that talks about the left postcentral gyrus receiving information about the texture of a fabric that you're touching with your hand. So what are some of the important words in that question? Left, postcentral gyrus. Maybe, maybe not. You don't even really need to know it's the postcentral gyrus, do you, for this question? But you could underline that. What else is important? Texture. You're receiving information. That's what kind of information is that? Texture. Sensory information. That should jive with the fact that it's the postcentral gyrus. So which spinal nerve did this signal enter the spinal cord? So it's ascending, I agree. It would be afferent. You've got 4 real choices and then 1 extra choice. What do you all think? Did you already forget this? It's A. Why is it A? I agree with you, but tell me why. Okay, so it's innervating onto the left side of the brain, so it's originating from the patient's right side. This is an anatomical view, so anterior is towards the front, posterior is towards the back. So we come in from the right side, and we're going to come in the posterior aspect because it's an ascending track, and it's sensory information, which are afferent fibers. All of that makes sense? Okay, cool. The other things that I'm going to remind you of that we didn't really get into on the exam, but we spent a lot of time on it in Unit 3, are parts of a reflex and then 2 structures. So the parts of the reflex, we've got sensory receptor, afferent neuron, goes to an interneuron, goes to an efferent neuron, to the effector organ, Could be skeletal muscle if it's a somatic reflex, or it could be smooth muscle, like if it's in the gut, or if it's in the bladder, right? Or if it's in the GI tract for defecation. Visceral reflexes, and we'll look at a cardiac one as well. So we talked about those reflexes. We talked about the 4 main characteristics of a reflex. Who can tell me what those are? The 4 main characteristics of a reflex. It was just a week ago. I know we had an exam in between. Stereotypical. Rapid. It needs stimulation. Sensory input would be considered the stimulation. Yep, and the 4th one? Involuntary. You don't think about it. Okay, so you should all have those 4. Then we talked about 2 examples. We talked about the muscle spindle. Who can tell me what the muscle spindle detects? Changes in what? Muscle length. Thank you. Well done. Where the muscle is, the length of the muscle, so that you can protect it. The Golgi tendon, what did it go over? What does it monitor? It's not muscle length, it was what? Tension. Nicely done. Okay, so now that information we're not going to forget, and it's also relevant because these are examples of reflexes. Now we're going to go from here, and we're going to talk about different types of reflexes. So here's what I want you to do. I want you to partner up and get your phones out. You're like, what? Get your phones out. Find a partner. You have to have a partner with your phone out. You with me? Phones are out. All right. With our phones out, I want you to, decide who's operating the phone, then you're going to switch places. You're going to get your flashlight out, and you're going to quickly put the flashlight up to your partner's eyes, and you're going to watch what happens to their pupils. Ready? Go. Oh, it's starting to feel like a rock concert back there. That's awesome. So you might need to do it, like this. Ready? And then you kind of put it over. Don't just be like, bam! If you're not getting anything, have your partner close their eyes and then do the flashlight from the side. Okay? And watch what happens to the pupil. And then switch. You see that? Did it work? Are your reflexes working? Okay, tell me what you saw. You're still seeing bright lights? Yep. What happened? Anybody? What happened? The pupil constricts. Why does the pupil constrict when the bright light's in there? What's it doing? It's not to focus, but that's a good guess. To let in less light. Why would you want to let in less light? So you don't damage the eye, you don't become blind. So it's a reflex that you don't think about. Are you thinking about constricting your pupils? No. It's an autonomic reflex innervating an effector organ that's protecting you, just like the Golgi tendon, just like the muscle spindle, And these types of reflex arcs are found throughout your body, all sorts of different places. Okay? Most students think like, oh, the reflexes, yeah, you go and they do that hammer thing, and I'm never very good at it. You know, they always make me have to like get distracted, and then they hit my knee and my leg kicks. Your body is built around these reflexes, stuff that you don't even think about, that go through what part of the brain? What part of the brain do you think circulates this reflex? Oftentimes, it's at the spinal cord, or how far up would it be? If it's automatic and you're not thinking about it, doesn't take higher thought processes. What part of the brain? Hindbrain? Maybe a little lower than the hindbrain? What do you think? Give me some structures. Pons, medulla oblongata, you're at the brain stem. Okay, this is going to help you this week in lab, because you're going to be dissecting brains, you're going to be looking for cranial nerves, you're going to be talking about the architecture of the brain, and you already know how it's organized. Okay, so reflexes, critical to our survival. So let's look at a couple of these specifically, and I'm going to show you a couple of videos today. So what are these visceral or autonomic reflexes? Well, they're triggered unconsciously. You're like, well, wait a second, I was awake when we did the pupil exercise. You were awake, but you weren't thinking about what was happening, right? Some of you were just laughing, right? Wondering what the heck's going on. Unconscious. They're automatic. They're stereotyped. Now, many of these visceral reflexes, in contrast to some of the somatic reflexes, they are not fast. They're slow. They're slower to respond. That's a difference from what we covered in the last unit. What I just went over that I said is fair game for the next exam, muscle spindle, Golgi tendon, what are the common characteristics of a reflex? When you're dealing with autonomic versus somatic, these are slower. You're controlling critical functions in the body, like heart rate, whether to urinate, whether to defecate, pH balance. You don't want to make aggressive changes all at once, right? Like, oh boy, I got to go to the bathroom. Bam, you got to, right? It's very inconvenient. Changing heart rate. You don't want to do things too fast. You're dealing with a very critical organ. Slower. It does involve visceral receptors and effector organs. So take a look at this picture for a second. You can follow the numbers. Right here we've got the baroreceptors that are in the common carotid artery. So this is the aortic arch. It comes up to feed the head through the carotid vessels. You'll learn more about this in 202 next semester when you look at the cardiovascular system. But you've got two carotid vessels that go up to the head. In the common carotid artery, before it bifurcates to the external and internal carotid artery, is where you find these baroreceptors. And the glossopharyngeal nerve, which is cranial nerve what? Cranial nerve 9. The glossopharyngeal nerve, cranial nerve 9. It receives this signal as a sensory afferent pathway to the medulla oblongata through an interneuron and then out the vagus nerve, which is cranial nerve what? 10. It'll become more clear this week because in lab you're going to go over these. The vagus nerve, cranial nerve 10, innervates and terminates on the heart. And it actually lowers heart rate. So this is a baroreceptor reflex that's autonomic. You don't have to think about it. When you have too high of pressure that's detected on the blood flow's way to the brain, you trigger through these cranial nerves that you're going to learn about in lab this week, 9 to 10, to actually slow down the heart rate and render your baroreceptor reflex functional. All right, so let me show you a quick video. on the baroreceptor reflex? Uh-oh. Hang on. I had muted it.
Homeostasis. Baroreflex is a rapid negative feedback loop in which an elevated
Video foul. Sorry.
Baroreflex or baroreceptor reflex is one of the mechanisms the body uses to maintain stable blood pressure levels, or homeostasis. Baroreflex is a rapid negative feedback loop in which an elevated blood pressure causes heart rate and hence blood pressure to decrease. Reversely, a decrease in blood pressure leads to an increased heart rate, returning blood pressure to normal levels. The reflex starts with specialized neurons called baroreceptors. These are stretch receptors located in the wall of the aortic arch and carotid sinus. Increased blood pressure stretches the wall of the aorta and carotid arteries, causing baroreceptors to fire action potentials at a higher than normal rate. These increased activities are sent via the vagus and glossopharyngeal nerves to the nucleus of the tractus solitarius, the NTS, in the brainstem. In response to increased baroreceptor impulses, the NTS activates the parasympathetic system, the PSNS, and inhibits the sympathetic system, the SNS. As the PSNS and SNS have opposing effects on blood pressures, PSNS activation and SNS inhibition work together in the same direction to maximize blood pressure reduction. Parasympathetic stimulation decreases heart rate by releasing acetylcholine, which acts on the pacemaker cells of the SA node. Inhibition of the sympathetic division decreases heart rate, stroke volume, and at the same time causes vasodilation of blood vessels. Together, these events rapidly bring down blood pressure levels back to normal. When a person has a sudden drop in blood pressure, for example when standing up, the decreased blood pressure is sensed by baroreceptors as a decrease in tension. Baroreceptors fire at a lower than normal rate, and the information is again transmitted to the NTS. The NTS reacts by inhibiting parasympathetic and activating sympathetic activities. The sympathetic system releases norepinephrine, which acts on the SA node to increase heart rate, on cardiac myocytes to increase stroke volume, and on smooth muscle cells of blood vessels to cause vasoconstriction. Together, these events rapidly bring up blood pressure levels back to normal. Baroreflex is a short-term response to sudden changes of blood pressure resulting from everyday activities and emotional states. If hypertension or hypotension persists for a long period of time, the baroreceptors will reset to the new normal levels.
Okay, so that last piece is kind of critical. So in patients where you have hypertension that persists for a long period of time, they actually have this reset, and their body no longer slows down heart rate. So then you have to put them on medications to actually do that instead. Make sense? So you'll put them on beta blockers, for example, things that will actually slow down heart rate. And we'll talk about more of these types of neurotransmitters and the effects of acetylcholine and norepinephrine on Wednesday. Okay, so I'm just kind of introducing some of these key concepts today, and then we're going to build on these as the week progresses. And hopefully what will happen is you'll be able to understand how the reflex that we studied in last unit, and then we reviewed at the beginning of this unit with respect to somatic or muscle effectors, plays a similar role when we're talking about them for autonomic or automatic or visceral nervous system. So, baroreceptors detecting a change in blood pressure, sending a signal to the brainstem, back to the heart, slowing down heart rate to drop heart rate and lower the pressure. This is an example of a positive feedback loop or a negative feedback loop. What do you think? Negative Why is it a negative? I agree, but why? Because the response is in the opposite direction of the stimulus, right? So the stimulus is, I have high blood pressure. The response is to lower heart rate so that you lower blood pressure. Does that make sense? That's a classic negative feedback loop. Positive feedback loop we talked about in the very beginning of the semester. What were a couple examples of positive feedback loops? Do you remember? Wait, how about in the back? Sorry, because get some new blood here. Pregnancy, specifically contractions during pregnancy for delivery, yeah. Did you have another one? Nope, that one? Anybody else? There's another really important one you shouldn't forget, yeah. Orgasm, yeah. Aren't you glad it's positive and not negative? That would be like, wah, wah. Okay. I'm just saying, I mean, come on. You're thinking it. I'm just saying what's on your mind. I'm very grateful for that positive feedback loop, and I imagine you are too. Okay, so let's look at the components. Let's look at the components. Receptors, afferent neurons, interneurons, efferent neurons, and effectors. Very similar architecture that we've already studied. Okay, let's look at a second example. This one's called the mituration reflex. And this one has a little bit, like, their little copyright thing is in the way, so just try to look past it.
Neural control of urination, micturition reflex. When the bladder is full, stretch receptors in the wall of the bladder send nerve impulses to the sacral region of the spinal cord. By way of a parasympathetic response, signals return to the bladder and stimulate contraction of the muscle of the bladder and relaxation of the internal urethral sphincter. This part of the reflex is involuntary and is predominant in infants and young children. As the central nervous system matures, it acquires voluntary control over the external urethral sphincter. Urination is controlled mainly by the micturition center in the pons.
Remember that?
This center receives sensory signals from the bladder and communicates with the cortex about the appropriateness of urinating at the moment. At times when it's not convenient to urinate, the center sends back an inhibitory signal to keep the sphincters closed and prevent voiding. When you wish to urinate, this inhibition is removed. The spinal cord instructs the muscle of the bladder to contract and the sphincters to open to let the urine out.
Make sense? Just another example of a reflex that you probably take for granted. Right? You take for granted until it's not behaving the way it needs to behave. Trying to get my, hang on one second. Okay. Questions? Thoughts, comments on mituration reflex or baroreceptor reflex? Does those two examples help kind of cement or allow you to kind of see how this operates? You know, and mituration reflex is an interesting example because it's sort of like this intersection between autonomic, which is involuntary, and then your ability to override it, right? And that happens as you potty train, right? As children grow and they become socialized and they say, okay, when you feel the urge, maybe it's not the right time socially, so let's send signals down to inhibit the release of urine, right? That's the voiding part. So you contract your external urethral sphincter. And as we age, maybe this is your question, as we age, our ability to have strong external urethral sphincter control dissipates. Just like a lot of muscle tone in the body dissipates as we age. So if you look at a geriatric patient, in general, the muscle tone in an older patient, the visible muscle that you see is going to be very different than the rest of you in this classroom. Right? And so what's happening in skeletal muscle in our older patients is happening in other types of smooth muscle that you have voluntary control over, like external urethral sphincter. And that's why incontinence is a problem as we get older. Was that your question? Make sense? Okay, so let's just recap real quick before we move on. We've got the autonomic nervous system. We're in the periphery. We're actually capturing the use of our cranial nerves. You're going to study them in depth this week in lab. You're going to kind of commingle cranial nerves, which are part of the peripheral nervous system, with brain, central nervous system, because it's a nice, convenient prep to dissect. Right? You get a sheep brain, and you can see them on the underside of the brain. But they're truly part of the peripheral nervous system. But that's the reason why we kind of put them together in lab, because you buy a brain, it's an investment, we might as well study everything associated with that brain. Right? And now you're kind of putting together the pieces of the puzzle on reflexes, why they're important. Right? They control things like how do you get nutrition out of your environment? Right? How do you eliminate waste? When do you eliminate waste? How do you control heart rate? Make sense? Okay. Autonomic nervous system divisions. So we've got big divisions known as sympathetic and parasympathetic, and we've introduced these concepts. We're coming back and we're going to get into more depth. We're going into the weeds on sympathetic and parasympathetic nervous system. But true to what we said before, sympathetic is fight or flight. Fight or flight. It is important for, hang on my notes here. 1 second, let me figure out what's going on. I think this, wait 1 second. The video messed up the link. Let me just reset. Yeah, there we go. Okay. And then that works. All right. So, sympathetic nervous system, that first blank, that increases heart rate, blood pressure, breathing or respirations, blood glucose levels, skeletal muscle perfusion. We've talked about a lot of these in the past. Just reiterating. So all of the things that you need in order to run away or stay and fight. You need higher heart rate. You need to pump blood greater. I mean, you've seen this, right? You've woken up in the middle of the night to some alarm. You don't know what it was. Maybe it was a fire alarm, right? In like 1001, 1002, 1003, and all of a sudden your heart's like, you went from a deep sleep to your heart is coming out of your chest. You're like, what the heck is happening right now? That is the sympathetic nervous system flooding your body with adrenaline, otherwise known as norepinephrine, coming from the adrenal medulla, because it wakes you up and you're ready to go. You don't know where you're going, right? Because you were just sleeping. Some of you are smiling like maybe this just recently happened, okay? Or you forgot to turn off, do not disturb on your phone, and your phone starts ringing. So blood glucose upregulates because you want to perfuse the exercising muscle with energy in the form of glucose, sugar. You increase muscle perfusion because you need to deliver that blood glucose and oxygenated blood to the muscles that are going to exercise. Okay, you decrease perfusion to the skin, to the digestive tract, because The skin is the largest organ in the body. We covered that already, right, with the integument. You don't need the blood flow to go to the skin. You need it to go to the exercising muscle, the soon-to-be exercising muscle. The other thing that you don't need to do is send a lot of blood to the gut for digestion. And if you're deep asleep, that is when most digestion takes place. So you move all that blood out of the gut and quickly to cardiac centers as well as skeletal muscle centers. Okay? That's what happens with the sympathetic nervous system. Okay, in contrast, the parasympathetic nervous system. Feed or breed or rest and digest, calming activities. It reduces energy expenditures. That's the first line, or first blank. It supervises or oversees digestion and waste elimination. And often, you've got both of them on at some basal level. Some basal level. You know, it's like your sink has a hot and a cold knob. And you don't typically turn on just one without the other if you have very extreme temperatures, right? You'll turn on both and get something in the middle. Does that make sense? If your hot water is really hot, you turn on your hot water and you just turn a little bit of the cold water so you get nice warm water that doesn't burn you. So there's an underlying autonomic tone all the time in our bodies where both are active at some basal level. So what parts make up this sympathetic nervous system? We call it the thoracolumbar division because of where the nerves come off the spinal column. In the thoracic and lumbar region, the nerves that exit off the spinal cord at that level are part of the sympathetic nervous system. And what you can appreciate is, here's the adrenal medulla, right above the kidneys, or the adrenal gland, I should say. And it's right above the kidney. It's labeled adrenal medulla, but there's a medulla that's on the inside and there's a cortex that's on the outside. So the correct label would be the adrenal gland. But this is where you're going to generate sympathetic adrenaline, or the secretion of what we call epinephrine, known as adrenaline, and norepinephrine, abbreviated epi, and then NE. And norepinephrine is called noradrenaline. So this is that flood of energy that you feel in the middle of the night when you wake up to some sort of fire alarm. And what's causing your heart rate to ramp up quickly is this flood of adrenaline or epinephrine. So this adrenal medulla that sits above the kidney is a modified sympathetic ganglion. If you remember a ganglion when we studied it, it's just a collection of nerve cell bodies. So many, many nerve cell bodies, but they're manufacturing this hormone that actually drives the sympathetic nervous system response. You can see all the different organs that are being innervated off of the sympathetic nervous system. You can appreciate you've got postganglionic fibers to the skin, blood vessels, and adipose tissue of the integument. We've covered the heart. You've got the lung for respirations. You've got a celiac ganglion here, a collection of nerve cell bodies. You've got a superior mesenteric ganglion, a collection of cell bodies, and inferior, just below that, in the mesenteric region, that's the gut, that feeds all of the intestines. You can see that the inferior comes down to our reproductive organs as well as our bladder control. Okay, so that's the thoracolumbar of the sympathetic nervous system. The adrenal medulla, just a little sketch to kind of demonstrate. Here is our spinal cord preparation. We've got our dorsal root horns and our ventral root horns. You can appreciate this motor efferent coming out, stimulating the medulla, which is the inner part of the adrenal gland, to release epinephrine and norepinephrine into the bloodstream. It releases into the bloodstream. A couple of seconds later, it hits the heart, and that's that 1001, 1002, 1003. Right? Here's another example. You're in traffic. It's snowy, it's icy. Some idiot cuts you off. All of a sudden, you grip the steering wheel, and in 1001, 1002, what happens? Heart rate goes up. You feel this rage come over you. That's the sympathetic nervous system. That's the flight or fight response. You with me? I'm not advocating road rage. I'm just saying, I imagine you've seen somebody that wrestles with that. Okay. Parasympathetic nervous system. Cranial sacral division. Why do we call it the cranial sacral division? Any guesses? It's on the picture too. Where do these nerves leave? They leave at the level of the brainstem, right? Cranial. Look at all of these cranial nerves that you're going to see in your sheep brain dissections this week. And in the sacrum. So the parasympathetic nervous system. What's interesting to me, just the way it's organized, is even though it comes out of the brainstem, it comes all the way down here and still has control over our gut. Because it actually finds these plexi. Remember these plexi that we talked about? Here's the pulmonary plexus, the esophageal plexus, the abdominal aortic plexus, and then it innervates on all of our abdominal organs. So, because the parasympathetic nervous system is really important to control digestion. But it doesn't come off where you would think at like the thoracolumbar region. It comes off way at the top. But it makes sense if it comes off at the top at the level of the brainstem, because that controls a lot of autonomic functions if you're exiting out at the level of the medulla and the pons. Remember that architecture? So we've got a couple of, usual suspects. We talked about the glossopharyngeal nerve, cranial nerve 9. We talked about the vagal nerve, or the vagus nerve, cranial nerve 10. You can see the facial nerve, the ocular motor nerve. You'll cover these. These are the two that I'm most interested in you understanding, is the glossopharyngeal and the vagus nerve, because we looked at that baroreceptor reflex for lecture. For lab, you're going to need to know all 12, and you'll have to know their names and what they do and all that. You with me? The enteric nervous system. So, in the very beginning of today's lecture, I talked about how we've got the peripheral nervous system, we've got our sympathetic and our parasympathetic. And then I said at the level of the gut, we have almost a specialized subdivision of the nervous system, and we refer to it as the enteric nervous system. In fact, it operates autonomically and in of itself on its own. If you were doing research and taking a fresh prep of intestinal tissue, you could actually put it on the benchtop, you keep it perfused, give it nutrition at the right body temperature of 37 degrees, and you can still measure GI motility. Same thing with the heart, right? You take a heart ex vivo, it has intrinsic electrical capability. And so the heart will beat ex vivo or de-innervated, it'll beat all on its own. That's kind of the amazing thing about the heart. It's also one of the challenges with disease, right? Because the heart kind of behaves on its own, and then you innervate it with parasympathetic and sympathetic activity. And so if it's not responding well and it's kind of doing its own thing, and you have these little ectopic electrical signals or bad electrical signals, then you eliminate them. And how do we eliminate them? Anybody know? On the heart? Anybody heard of ablation? Cardiac ablation? So you come in and you actually eliminate the nerve signal in that location from the heart tissue itself. With a cauterized or a cryoprobe, you ablate that signal to keep it from doing it. So the heart and the gut will actually contract and have motility ex vivo all on their own. And at the level of the gut, it's this myenteric plexus that stimulates that activity of nice, slow reflex contraction, relaxation, contraction, relaxation. A nice, if you measured it, it's a sinusoidal contraction, relaxation, contraction, relaxation. Just enough to pack the food, push it through the GI tract, but at a speed that's slow enough that you can absorb the nutrition, right? But fast enough that you can eliminate and excrete waste products into the lumen. Okay? So parasympathetic and sympathetic nervous systems both have activity here. The enteric nervous system is this subdivision of the autonomic nervous system, but it directly controls this GI tract. So the plexus here has about 100 million neurons in the wall of the digestive tract. It's pretty incredible how many neurons that are here. Okay, let's talk about the anatomy of the sympathetic nervous system. And I've circled 3 very specific pathways here that I want you to be familiar with. So if we look at the sympathetic nervous system, the SNS, and you look at your spinal cord prep, we have the effector organ, the effector neuron coming out, and we've got these red boxes up top, in the middle, and down low that are sending this signal on the sympathetic nervous system to different effector locations. Okay, let me repeat that. Our spinal cord prep, this is the neuron. We're going to call this the preganglionic neuron. That's a term that I'm introducing. We'll talk more about that on Wednesday. And this preganglionic neuron is going to actually innervate and send signals in a couple of different directions. So it can send it this middle direction, it can send it up, or it can send it down. If it sends it through the spinal nerve, which is the middle direction, the spinal nerve innervates muscles and the body wall. So you can see some of the examples that are listed here in this red box. The spinal nerve sends, the effector organ is sweat glands, piloerector muscles, blood vessels of the skin, and the skeletal muscles. So that's getting your skeletal system ready, right? You hear a loud noise. You're camping in the woods. It's dark. You hear a loud noise. All of a sudden your heart rate raises and the hairs on your arm stand up, right? So that's spinal nerve activity to the skin and the piloerector muscles. If it goes up here, it's also sending it to your heart. You know your heart's beating fast. That's actually through what we call the sympathetic nerve. Iris, the eyes, salivary glands, lungs, heart, thoracic blood vessels, and the esophagus. So that's getting your heart and your lungs ready through the sympathetic nerve. The third one, the splanchnic nerve that sends it downwards, innervates the abdominal cavity, which makes sense. It's coming down instead of going up. Abdominal cavity, the listed organs here, we've got liver, spleen, adrenal glands, stomach, intestines, kidneys, urinary bladder, and reproductive organs. So this is the 3 routes by which a sympathetic nervous system response is an entire body response on fight or flight. So the parasympathetic nervous system. So the parasympathetic nervous system looks a little different, right? The parasympathetic nervous system here, we see a long presynaptic axon that travels to some terminal ganglia. And the terminal ganglia are all the way in the periphery. Whereas the sympathetic nervous system kind of uses this relay center where it uses these 3 relay points: spinal nerve, sympathetic nerve, and the splanchnic nerve. So these terminal ganglia that are out in the periphery, you can kind of appreciate up top here, we've got our ciliary ganglion, our submandibular ganglion, we've got our celiac ganglion. So all of these are out really in the periphery, distributing the signal. So now let's kind of compare and contrast these two different pathways. And I want you to talk with your lecture partner, whoever's nearby, and just write down a couple of observations for me. Okay, write down some observations. You have one pathway up top, and you have a second pathway down low. Write down some observations. There's nothing incorrect or correct. I just want you to observe and take notes. I actually meant now, like ready, set, go. Okay, just popcorn style. Give me some examples of things that you notice through these two different pathways. Become more important on Wednesday, so we're kind of setting the tone for Wednesday. What do you see? What's that? The first one's faster? How do you know it's faster? It's completely myelinated. Oh, okay. All right. I was like, there's no velocity data there, but that's actually really good. Okay? So this one's completely myelinated up top. The inference would be a faster route. This one has a myelinated preganglionic and an unmyelinated postganglionic. So I'd actually probably go with that hypothesis. I actually don't know the answer to that, but I think you're probably right. I like that. That's what I wanted you to just observe. Okay, what do you have? So 2 synapse points on the bottom one versus 1 synapse point on the top, right? So you've got a ganglion, an autonomic ganglion on the bottom pathway, right? So that's a synapse point. I agree. Obvious difference. What else? Okay, so myelinated on the preganglionic fiber on the bottom, unmyelinated on the postganglionic fiber. The top one, as your colleague pointed out, probably is faster. There's no pre- and post-ganglionic fiber. There's just a myelinated fiber that goes from the spinal cord to the effector organ. I agree. Great observations. In the back? Neurotransmitters. Talk about those. What do you notice about the neurotransmitters? They both use acetylcholine. However, the autonomic uses norepinephrine on the secondary innervation point. Okay? Remember, one of the values or the benefits of having neurotransmitters is control. That you can actually influence and decide what to do at that location. You can shut off the signal. You can make the signal last longer. You could amplify the signal. Okay, so you have 2 different points at the bottom versus 1 up top. 2 different neurotransmitters. Anything else? Different target tissues. One's a skeletal muscle up top. One's a cardiac muscle down low. So you've got somatic up top, which is typically under voluntary control. And you have autonomic, visceral, another word for visceral, on the bottom, which is typically under involuntary control. Okay. So I want you guys to kind of see how this looks in a table format. And this is some of the things that you were actually talking about. Like, for example, look at neurotransmitters for the colleague in the back. Acetylcholine on somatic, acetylcholine and norepinephrine on autonomic. Okay, so you're picking up on the exact things that the authors of this particular textbook were picking up on. So the effector organs on skeletal. Effector organs on somatic, skeletal. Effector organ on autonomic, glands, smooth muscle, cardiac. So this picture could be smooth muscle or glands, because those are involuntary. Does that make sense? Controls. What is this control? This one usually is voluntary. This one's involuntary. Does that make sense? Can you control skeletal muscle? Typically, yes. Can you control, or is this under involuntary control? Generally speaking, it's under involuntary control. Is this table making sense? Okay. Efferent pathways. Over here, we talked about one nerve fiber from the CNS to the effector organ, no ganglion. Over here, it's synapses at a ganglion, right? We're talking about this has two fibers with a rest stop in the middle. This one just is like a one-way, non-stop ticket. We already talked about acetylcholine. Okay, effect on target cells. We didn't talk about this. The effect on target cells, at the somatic, it's always excitatory. Autonomic can be excitatory or inhibitory. Well, that's different. Because we have more control here by having different neurotransmitters. You can release acetylcholine or norepinephrine here. Do you think that's how you get the excitatory or inhibitory? We'll talk about that on Wednesday. Now, if you have denervation, you cut the nerve. You cut the nerve under somatic skeletal muscle. It's called flaccid paralysis. The muscle is stuck in a relaxed state. That's what that means. Flaccid means relaxed. So flaccid paralysis, if you deinnervate, you cut the nerve, you lose innervation, the muscle will be permanently in a non-contractile state. In contrast, autonomic, if you deinnervate, you have what we refer to as hypersensitivity. It's overactive. Overactive. So your homework for Wednesday, and then we're finished. Finished a little early. Your homework for Wednesday is to be able to define a somatic reflex arc, which was picture number 1, the top pathway, and talk about its major parts, and be able to define and explain a visceral reflex arc, which was the lower pathway. So this is a somatic reflex arc. This is a visceral or autonomic reflex arc. Does that make sense? So that's your homework between now and Wednesday. Okay, have a great evening.